Thank you very much. Hi, everybody. I guess I'm the sort of one of the last acts here. So it sounds like you've had a great day. You know, giving a talk on technology at an innovation center is pretty amazing. I'm old enough to have started my medical career really before CT scanners, well before MRI. So it is just stunning what has sort of happened over all of these years. And of course, you know, the computer stuff has had some highs and had some lows. And the Office of the National Coordinator was founded in 2004, I think with hopes for further highs and maybe some plans to raise up the lows. And so for folks who don't know, the Office of the National Coordinator is one of the staff divisions in Health and Human Services, so report up to Secretary Price. And it's really the agency to set the regulatory environment, but also the sort of broader healthcare IT environment for the United States. We have about 180 employees, just to give you a sort of a scope of the agency. A lot of the things that you probably have heard about, the meaningful use, that was part of the High-Tech Act. And we probably now have roughly 80% of outpatient practices with electronic health records, electronic medical records, and almost all inpatient practices. So there's been a lot of progress in getting computers and software up and running. There have been a couple bumps in the road as well, so I think can be candid here, I hope, in this audience. And so the evolution of things is really, you know, what have the things that need improvements, or where are we on those things? And that's really the go-forward mission of the agency. And the two areas where there have, I think, been identified nationally, the sort of biggest rooms for improvement in electronic health records, which is, I know, one part of what you're talking about here today, but arguably, at least in our view, one of the central parts, are usability. So what is often defined as the provider burden, sometimes referred to as a physician burden because it tends to fall the most on physicians as the sort of business leaders in their practices typically. The other part is really interoperability. I think there was an assumption and a hope that once we have these electronic medical records, we have some of the seamless data flows, that we have, you know, sitting in our pocket or our purse with our smartphone. And so those are really the sort of the go-forward goals. Congress has recognized that with the 21st Century Cures Act. Have folks heard of this bill? I'm just sort of curious. Maybe a quick show of hands. And who's heard? Okay, well, everybody. Okay, I guess it's all in the right audience. So the go-forward mission for ONC, a lot of it comes from the 21st Century Cures Act, which we're going to talk about in a second. The other part is the law, the Medicare Access and Chip Reauthorization Act, known as MACRA in the trade jargon, and the quality measures there are sort of the Medicare, the merit-based performance measures, sort of known in jargon as MIPS. So those are the big regulatory definers of our role, and I'm sure a number of you will be sort of interacting in that space. Let me talk a little bit about what, at least in my experience, are the challenges with both usability and with interoperability to give people a flavor of it. I think the usability is very interesting. I think it's a tough thing if you're going to sort of set policy. But I've sort of noticed two things I'm just going to throw out about usability. And part of this is spending a long time as a developer of electronic medical records. One of the challenges with usability is that while, let's say, every clinician has a pretty good sense that they know exactly how to design software, because, you know, after all, we're a doc, so, you know, sort of innate. Just kidding. But seriously, absolutely seriously, folks really think that. And so developers, so, you know, the folks sitting on the other side of the table, so the folks writing the code, take pretty much literally what they've been told and put that into code. The problem with that is sort of interesting cognitively, which is that clinicians think and have been trained, for many years, a long training period, as you know, to believe that they're sort of logic machines. Sherlock Holmes. If everything else has been rolled out, this must be it. Well, the problem is that clinicians and doctors are, in fact, use the same core brain processes that everybody else, which is pattern recognition, right? We wouldn't have survived if we were logic machines, right? You have the saber-toothed tiger coming at you, and you're thinking, let's see, is that a mammal? Let's see, is that a carnivore? No. Shit, I better get out of here and run, right? So clinicians are pattern recognizers and not logic machines. That's a whole different style of programming and a very different thought process, and that's very, very hard to capture and almost invariably lost in translation in that whole sort of usability space. The other subtle thing that I think makes usability of these systems a big challenge is also sort of an interesting thing, which is, so we talked about the clinician side of the equation. On the developer side of the equation, anybody here do an undergraduate degree in computer science? A couple folks. So I think if you sort of remember back, we were taught that we basically should be reusing code libraries, code reuse, right? Don't write new stuff if it's been debugged in code reuse. The problem with code reuse on user interfaces is all of those user interface tools, whether it's Java FX or, Spring or whatever, Swing, Microsoft Foundation classes, pick your tool, they were designed for people who are sitting at a desk in relatively static things. Most clinicians are in very, very interrupt-driven situations. If you're practicing in a primary care practice, you're getting an average of 200 inbound phone calls a day per clinician, right? Many, many, many interruptions around all of this. If you're sitting in an ER or an ICU, you're interrupted almost every minute by something or other. And so our software, our UIs, haven't really incorporated that. And so that's a real challenge on usability. We'll talk more about things we can do here. So let me shift a little bit of focus to interoperability and some of the challenges there, because understanding the challenges, again, is how you come to the solutions. So interoperability has a lot of facets. There's some very technical things, just sort of transmission, the 7-layer stack for folks familiar with that. There are a lot of business issues with interoperability. Then there are a whole bunch of interesting vocabulary issues, sort of what is called semantics, sort of the meaning, right? So exactly, we talked about blood pressures on the iPhone a second ago. Well, exactly what is a blood pressure? What type of blood pressure? Do you bundle these? Do you unbundle them? Is it sitting? Is it standing? Is it first sitting and then standing? So there are a lot of definitional things in healthcare, and there's been a lot of progress made in this space, but there's some work to be done. So that sort of, I think, hopefully paints a little bit of the technical backdrop. So when you look at it from a policy point of view, the Cures Act, which is our main driver of interoperability, so the 21st Century Cures Act, sort of the Section 4 there, has a couple of different legal mandates of Health and Human Services and our office. They're very broadly positioned mandates. So one of the mandates is pretty much, there shall be interoperability, right? So it's not exactly defined, but Congress, the Cures Act, by the way, was passed almost unanimously. I think it was something like 390 to what, 20 odd. So interoperability, one thing. Another big call out is a prohibition against information blocking. So now information blocking, as you might imagine, is a very, very complicated thing. Is that interface not working because of business reasons, active blocking, technical things, a combination of the above? The final thing that's very interesting as a mandate in Cures is the concept and requirement for open APIs, so application programming interfaces. I think this is very interesting because this is really going to potentially open up a lot of healthcare to a number of the innovations that we've sort of heard about here today, which really need an open API in order to get data and to share data. So Congress is really very much on top of this and facilitating that. There are a couple, as we look at interoperability, I think there are a couple sort of large stakeholder groups to think about. The first one are patients. It is not widely known, I don't think, but patients actually have a right today under the HIPAA law to get their record electronically within 30 days. Presumably the electronic transmission doesn't take 30 days, but to get their record within 30 days in a computable form, if there's an underlying electronic medical record, which typically there is. Now, it's still a work in progress to get patients to ask for that, but they actually have that electronic right. And the goal really here is to empower people to shop, right? Really to empower people to own their own data, to allow them to take responsibility for that data, and allow them to take it to the healthcare providers that best meet their needs. This is a big issue in having market competition. The second area where interoperability can help, I think, are just the massive transaction costs. We still, as clinicians, have, in most settings in the United States, massive issues with getting data from outside providers. Fax machines still run wild. Ohio State, where I've worked, had obviously a large tertiary referral center. It is a regular issue for the IT staff to have to service printers that got a 250-page inbound fax, and then the printer tray is off, the laser printer, and for the clinicians, the printer doesn't work, is the diagnosis. So there are some very interesting opportunities here on that from the provider stakeholder group. The final stakeholder group are some of the folks, I believe, here in this room, who are the entrepreneurs, the folks who want to do new business models, who want to compete, who want to innovate, who want to disrupt, right? We have not had really in healthcare the sort of the Googles and the Amazons and the Ubers, but with open APIs, I think there's a much better chance of having that, and that is a large priority, obviously, for Secretary Price, combined with the interoperability and the burden reduction, and obviously the President has spent a lot of energy on in discussions on how to increase market competition in healthcare. So that gives you hopefully a little sense of some of the stakeholder groups that we're sort of trying to target here with interoperability. And we can talk more about that in the questions. On usability, as we talked, it's a complicated issue. One of the opportunities we have in usability, that's often folks look at usability as, I don't like my computer. I think that's anthropomorphic, but I wasn't an English lit major, so if I got the word wrong. They don't like their computer. They don't like the computers. And if you survey docs, you'll find multiple hours a day, extra work on the computer, and has the computer made you slower? Absolutely. Very, very consistent findings. The part of the interesting challenge is that our documentation requirements, so for folks who live in the, quote, evaluation and management, this is the common procedural terminology, code space. So these are the codes that if you've had an outpatient visit in the United States that's not from an HMO, somewhere on your bill, somewhere you'll see these CPT codes. Those codes require, for the sicker patients, a lot of documentation. It was originally put in the 1990s as a proxy for time. It doesn't really make a lot of sense now because you sort of hit the template button and stuff spews out. Again, the challenge that we all collectively pay for, in many ways small and large, is the electronic charts now have a lot of relatively meaningless information in them. It's sort of called chart bloat. So we're working very actively with CMS, so Center for Medicare and Medicaid Services, and our other colleagues in Health and Human Services to see what we can do about some of these documentation requirements and the allied physician burden. One of the areas, electronic quality measures, which is a proxy for value that you often hear about with value-based purchasing. We're trying to smooth that out as well. So that gives you maybe a little bit of sense of what ONC is doing, and I think maybe by implication, some of the other activities at Health and Human Services that we're trying to do to make healthcare less expensive, more efficient, and provide ourselves as patients and our families better service. It's a pretty exciting time. I mean, anybody who's in technology, these are exciting days. The Moore's Law wave that we're surfing is just really a once in humanity kind of event, I think. Maybe that's sort of self-referential to our time in humanity, but it's a pretty exciting time, and we at ONC are excited to help where we can and get out of the way where we should. So with that, I think we'll open it up to questions. If anybody has any questions. Okay, end of day. Never ask for questions at the end. Great, thanks. Yeah, it's really embarrassing as a speaker. Man, was that bad? Oh, okay. All right, well, we have two. All right.
So the question, you talked about usability being a real challenge, and
Yes.
I'm curious, what is ONC doing right now in terms of efforts to improve usability? Are you doing, user research studies? Are you reaching out to the outside, the innovators, the true innovators in the space that are, taking usability as their main thing?
Yeah. So there are a couple things. So I think the first one is just as we go through the various regulations, making sure that there aren't things that we're requiring that are additional work, out of process work, and there has been some of that sort of over time. So that's one thing that just sort of ONC. The second part of usability is really working with the other agencies, because I think the part that we can affect is a lot of the documentation part of it, and there are a lot of potentially additional workflows with quality measures that we're trying to really sort of absolutely minimize. Those are the key things that we do. The part of it is honestly just getting out of the way of entrepreneurs, and we hope that the APIs, the open APIs and the definitions that are, that we hope to facilitate will allow easier access and more experimentation to different modes and different devices, right? Because a lot of this stuff is still anchored on, even desktop apps, let alone web. And, there hasn't been that much on healthcare, because the healthcare things that are out there, there are a lot that are sort of biosensor, the Fitbit type of thing, but the apps, if you will, have had a very hard time connecting to the health system data that they really need to add true value, right? So they've sort of had a very standalone nature. So we hope that those things, and then there are new technologies. I mean, speech. I was involved in 1988. We started, Data Medica's mentioned. We were the first company in the world, besides building the first company to do a Windows EMR, and I would strongly advise nobody to program in Windows 2.1. It wasn't a stable environment. But we were the first people to use Dragon ever in healthcare. I've been used a lot in the military, sort of cockpit awareness, but not in healthcare. And the comment about speech recognition in the 80s and 90s was it'll be ready in 2 years. And this went for several decades. But I think it's actually pretty effective now. And you're obviously the judge of that just on your phones often in that. So I think it's letting these multi-layered technologies and these different technology stacks come in and making sure that any rules we write don't unintentionally prevent that, as well as cleaning up some of the things in our house on usability.
Thank you for your comments and sharing.
Thank you.
So, question of the day, two-part question. Will the momentum for value-based payments bundles all flavors. Will that be accelerated or slowed down under the current administration? And if so, will there be a differentiation or a recognition of ACOs that are kind of led by physicians versus ACOs led by hospitals?
Okay.
Off
So,
the record, there's no reporters in the room.
yes. But that's what the benefit of a small audience with cameras.
That may not be true.
Yeah, with cameras going. So let me start with the first question, right? So I think it's worth understanding when the term value-based purchasing is used, right? So the measures of value-based purchasing, which are often sort of under the rubric of quality measures, are really very, very narrow proxies for consumer value. If you think back to college economics, right? Price equals marginal cost equals marginal utility. That's the efficient frontier for any of you who, that day in college. Well, when Medicare started fixing prices, and Tom Scully, one of the former administrators, used to call Medicare the largest price fixing scheme in the world, with the decline of the Soviet Union. When those prices were set administratively as opposed to market, consumers were in large part taken out of the equation. And so the value is an attempt to serve as a proxy for consumers, right? That is the economics of value. The proxies we are using right now come under the category of what are called quality measures. And this is a long discussion. We're not going to get into the details, but they're the kinds of things you might think if you have some clinical exposure in this area. A lot of that is in the law. It's going to go on. We're going to try to make it smoother. But I would argue that the true answer to your question is more the real goal of the administration is to try to empower consumers more, to let consumers define value rather than having us define value. But we will be defining value because it's in the law and there's a massive mechanism to do it. On the ACO question, I don't have any specific thing to say there. I'm not part of CMS, so it is not in my bailiwick to say anything specific about that. I think, ACOs are a legislatively defined activity that, again, tries to impute value. And I believe they're still a work in progress. I think the best way of looking at ACOs is a work in progress, and where that ends up in comparison to, for example, a health maintenance organization, a Kaiser, if you will, or some of the Medicare Advantage things. Where those things end up, I think, is still to be determined. But that's a different agency, so that one I think you'd have to ask CMS on. Any other questions? Hi, yeah.
You mentioned the 21st Century Cures Act and the idea that citizens and their representatives were asking for interoperability.
Yes.
You highlighted some technical challenges. My sense is that the challenges are not technical and that they're all about the policy execution. Can you articulate what exactly have been the obstacles to government doing what it's supposed to do, which is set standards and then let the private sector compete on those standards?
Yeah, so I hope I mentioned, but if I didn't, or if it didn't come across clearly, we see interoperability as a complex interaction of business issues, business practices, and a whole variety of things that are sort of technical but not necessarily bits and bytes, the vocabulary things I mentioned. So there's a whole stack of things. The trick, right, the real trick here is you have to move all of those different parameters near simultaneously, right? You have to have that sort of virtuous circle, right? It's not enough to just say, here's a standard. It's not enough to say, here's a business thing. And of course, some of this is, do you do it with regulation? Do you do it with incentives? So it's really trying to harness a number of these things simultaneously is what's going on. ONC has spent a fair amount of resources in advancing standards. So ONC has specifically been involved in things like LOINC, HL7, FIRE, RX Norm. We work with SureScript. So we've funded the health information exchanges, which are users of standards. We've encouraged Commonwealth, Care Equality, some of those organizations. ONC funded and started the direct whole program for point-to-point. So the agency has actually historically done quite a bit in this space. But the next steps, as with the prior steps, really are a delicate balancing act. I think you can take the sense of Congress that there was concern that some of these things are, there's some information blocking involved. So on that part, that's more on the stick side rather than the carrot side. Hopefully that gives you a sense. It's a big jigsaw puzzle of multiple simultaneous pieces we're working on there, with many, many interested parties, often on both sides of the both sides of the equation. Any other? Well, thank you very much. You've been a great audience at the end of the day, and continue the great work.